Okay, good morning. Last day today. I think people will come at different time. Alors, we have different lecture this morning to start with, and but we have to start to be on time because then we have live surgery starting at 9:30 sharp. So we have one case of deep endo global without any theoretically no more than bowel shaving, etc. And we have a case with a big bladder nodule, so in an anterior compartment. It will be interesting. And then we will get back to lecture. And so we have to look for the afternoon, so we have to be on time because we have to finish on time. So I mean that at 4 p.m. wrap finished because of issues with transportation, etc. Okay. We start now with a very interesting, you know that 85% or maybe 90% of the lesion of endo are on the posterior cul-de-sac. Posterior compartment, as we call, which is anatomically limited by the uterosacral ligament, the torus uterinus, the Douglas pouch peritoneum, the rectum on the back. So you have all anatomical structure there. You know you have seen during these 2 days the proximity of the inferior hypogastric plexus for the nerve, the right and left hypogastric nerve, and obviously the ureter and the vessels. Now, when we speak about the vessel, we are not too much worried on this location by the uterine artery or uterine vein. It's fine. We can always sacrifice the uterine vein and the uterine artery, even in young patients, without compromising the chance of being pregnant. But the most important vessel you have to pay attention in this zone is the Americans call that the tiger zone. It's the posterior branch of the internal iliac vein, which is close by here. And the problem is in endo is that it's retracted medially. And so this vein that normally is a little bit sided become quite at the level of the cul-de-sac. So if you injure this vein, it's a real bleeding. No problem you can sacrifice, but difficult. Okay, so we are going to see all this with Zainab. Yeah, the posterior trunk of the internal iliac vein. Okay, so let's go for this overview of the posterior compartment. Thank you, Zainab. I had a program.
Should be fine, yeah? Okay, thank you. Thank you, Professor. Before I start, and good morning to everyone, I just want to give a moment in the memory of Professor Jack Hamu that passed away 2 days ago. If you know the hysteroscopy and you know the endomat Hamu, he was the creator. And he had a lot of impact in our life, a lot of personal impact on Professor life, a lot of professional impact on our life, and we will always miss him. Okay, so we are starting about the posterior fornix and what are the challenges and what are the pitfalls in the posterior compartment and posterior compartment. I have no conflict of interest. I will just go very fast regarding the overview of endometriosis. We know that it is prevalence is around 10 to 15%, up to 20%. And we know 30 to 35% of women with endometriosis, they suffer from infertility. And up to 40% of infertile women have endometriosis. Now, regarding the location of endometriosis, if you see that the posterior compartment has the maximum location of endometriosis. We have it in the pouch of Douglas, uterosacral ligament, in the ovaries, And you see that up to 80% it is in the pouch of Douglas. A little fast review on the anatomy. We know deep infiltrative endometriosis, or DIE that we are calling, when there is subperitoneal invasion more than 5 millimeter in depth, and we are talking in anterior posterior compartment and the peritoneum. But in the posterior compartment, which is composed of the two uterosacral ligaments, torus uterinum, we have the vaginal wall, and we have the fossa ovarica and the rectovaginal septum. If you see here, this thickened band transverse, which is between the two uterosacral ligament insertion, this is called the torus uterinum. This is where we call it torus. And we know the uterosacral ligament are the smooth muscle fibroelastic condensation, which is starting from S2 to S4 sacrum, and it going to the cervix. And it's important because it gives the support to the upper part of the vagina and the uterus. So it tells that never trust a woman, even in her anatomy, but it's correct. You should not trust women. Because anatomy can change.
You can erase this for
Because we know that anatomy can change, however, not the landmarks. So that's why we are emphasizing on importance of mastering the landmarks knowledge, the anatomy of the landmarks. Because in endometriosis, the anatomy will change. The normal anatomy we know is not the same way that we see it, but the landmarks will never change. So what are the landmarks? Important landmarks in the posterior compartment is the ureter, example, is the hypogastric nerve, example, is the promontory, example, pouch of Douglas, example. And again comes the spaces. Important and very important to know the anatomy of all the spaces, because when you are mastering the spaces, and I'm not going to go in detail because it was covered, but knowing the spaces is where you will know and you will see your landmarks. So for example, if I see here, this is a pararectal, we are on the left side, you see that we have the ureter, here is the ureter. If we are lateral to ureter, we are the Latsko space. If we are medial to the ureter, we are in the Okabayashi space. You see the important landmarks which are in these spaces. For example, in this video, we are in Okabayashi space. We know in Okabayashi, we have the medial rectal artery. This is a landmark. By knowing this, we should know that now, dorsal, cranial, and lateral to this landmark, we should find the inferior hypogastric plexus. So we know this is a landmark. We will know that the hypogastric plexus, the inferior, will be there. Same important is the knowledge of anatomy of the ureter and pelvic ureter and its path throughout the pelvis. It was already talked, and the vessels. So let's go now to the real thing. When we know many studies has proven that laparoscopy surgery improves the fecundity rate in patients which are suffering from endometriosis and fertility, specifically the mild and moderate endometriosis. Now, whether resection or coagulation, nowadays patients ask you, are you an excisional surgeon or are you a coagulative surgeon? You just burn it or you excise it, because they read about these things and they ask. By studies, we know that the resection is much better and it is improving the fecundity rate in infertile women. So, for example, in this study, which was a retrospective study of 115 patients, and they did laparoscopy excision of deep infiltrative endometriosis, the follow-up, they saw that the pregnancy rate up to 55%, live birth of 45%, which is saying that excision of deep infiltrative endometriosis in patients increases the fecundity and fertility and live birth rate. Here comes the important that this beautiful publication by Chuck Miller, that it's not enough to be in the right place at the right time. You have also to be the right person. And this is what we are talking and advocating for pelvic surgeon and endometriosis surgeon. So when you are referring to endometriosis clinic, what are the important in it? We are asking regarding detailed history, previous history of the patient. You have to listen to your patient about this, the surgical history that she has, the clinical examination and investigation. We love to listen to our patient. It's very important. She will tell you stuff that it will help you a lot in predicting your surgery and your next step of management in general. In endometriosis clinic, we always ask this question, which is the typical Ds, the dysmenorrhea, dyspareunia, or even lack of intercourse because of the pain, dyschezia, dysuria, and the dull pelvic pain. We have this picture in our clinic note, and we show it to the patient. If she's having nerve pain, and we follow her dermatome. This also gives you a lot of information that can help you in your next step in the counseling and managing your patient. Of course, the importance of clinical examination, bedside gynae examination also can add a lot of information. Yes, nowadays not all of us do the examination because of the imaging has taken over. We all know this, but still information like this, you cannot see it in the imaging, you have to see it by your eyes in the clinical examination when you see this nodule in the vagina. In the imaging, we all do scan, but we are never like, we will not be like Katerina Exakustos when she's seeing the endometriosis the way she sees. That's why in our unit, we do MRI. We request MRI because not only that we can see the MRI and we can read the MRI, see the endometriosis, also we can cut the sections, provide the image and shape the picture that we want to see. And we can also counsel the patient in the same time and make shared decision with her. For example, this was a patient 2 weeks ago. She came from another country to Dubai to be operated by Professor. This patient, we see her MRI. This is the picture that we were talking and discussing it with her. And nowadays, a lot of patients are very much educated. They are very much informed thanks to ChatGPT and everything else. They see and they know what they have and they want to know. They want to know. So we show them this picture and we show them the picture of intraoperatively. And you can see that it is almost the same in the real life and in the MRI. So here comes a tailored approach that we are saying always listen to the patient, what she wants, what's her perspective from this treatment that she wants. We are always radical toward the disease, but we are very economic toward the organs and the function of the organ. So the aim here, either quality of life improvement or the fertility improvement, or both of it, or just preserving fertility, not only improvement. Preserving the fertility is also very important. So if you ask ChatGPT till today, if you now go on ChatGPT and ask, they will tell you what is the benefit of laparoscopy. Till now they say, smaller incision, less pain, faster you going home, the same things that we know. Yes, that's all correct, but we are not doing laparoscopy because of those things. We do laparoscopy because we do better. We know that we do better by laparoscopy. Why we do better? Why we do better? Because we know that we can shape the image, we can read and create the image that we want. We have a huge uterus, huge nodule. That is not important now. We are at this level and we are doing this surgery at this level. So this is the shaping of the image and information that you need to know in laparoscopy. Thanks to the pneumoperitoneum and the dissection that we get and the bubbles that we have, you can go into planes. We can have very good anatomical plane opening. We can have a better repair and better hemostasis by laparoscopy rather than laparotomy. So let's talk about the surgical techniques and principle. We have general strategy and then we have a specific strategy. Always in general strategy, and this is in all laparoscopy, we start this way. We observe first, we look, we observe, we understand, we expose, restore, and then reevaluate and decide and act. So this is the first thing Professor always, and we learn from him the same thing, that we examine the patient under anesthesia. Examination under anesthesia also will give you a lot of information that will help you during your surgery. Next, the good positioning and exposing a patient for exposure of the pelvis. Good communication with the anesthetist can give you a very good Trendelenburg position. You can discuss with your anesthetist and come into agreement that a good Trendelenburg can shorten the surgery time. It can help that the surgery goes better and faster, so they will also accept to give you the Trendelenburg. Sometimes you have obese patient, and this question was asked yesterday in the lab, that if you have obese patient, what you do? In this case, you just talk to the anesthetist that, okay, give me the Trendelenburg I need. I will put the bowel up. After that, you can slowly start putting it back the way you want till you see the bowel start coming back to the pelvis, stop. So you will reach to an agreement between you and anesthetist for the best position at this level. I want again to show this video, sorry. Here we are not doing anything, just by positioning, you see how the bowel goes away by itself. This is the first step. Then next step is here, that you will take the small bowel to the right side the large bowel to the left. Small to the right, large to the left. This is the best exposure. And keep it above the pelvic brim. And this movement is because of the Tots fascia embryological origin that can help the small stay on the right and the left stay on the large stay on the left. After that, we are opening the sigmoid, and this was discussed already yesterday. Then use of manipulator, it's very important. Use any technology, any other hand that you can to help you in the surgery. Using the manipulator will free your assistant, can be an active assistant, and can help you in the surgery. Suspension of the ovaries. You see here we are using the T-leaf to suspend the ovary. This is the same principle. We need to have a good exposure so we can have a good field for the surgery. The suspension, again, is not only just to keep it up because you want an active assistant to be actively involved with you in the surgery. So they say that general surgeons operate like this, and we have a general surgeon here, but gynae comes and mess everything up. That is not correct because we are learning it's not correct. So we have a special strategy and a special specific strategy that we have to follow after the general strategy that we said, and this is that you recognize your anatomy and mainly the landmarks that we discussed. You have to always surround the lesion, never confront it directly. Go from away of the lesion toward it, from lateral to the medial. We know endometriosis is a medializing disease. So always go from lateral and surround it and then go to it. Try to start in healthy tissue. Excise in sano as much as you can. We do the safety test and adhesion prevention. This is one of the specific strategy videos that we can see together. We see that the nodule here is here, right? This is healthy tissues, healthy looking tissues. So we are starting in a specific strategy away from the diseased tissue and always surrounded from the lateral part. So see in this video, we have the yellow part and the pink part, and we are going in this space to go in the pararectal space. You can see here again, we have the yellow, 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 pink. In this place, you go inside. In the slow motion, you can see the shear tearing of the tissue. Your traction and counter traction is in this direction, and your tearing is in this direction. According to the force that you are applying, you will have the tear you want. You have to be gentle, you have to have a controlled movement to avoid to have a lot of bleeding. If you are in the correct plane, you should not have bleeding. If you are not in correct plane, you will have a lot of bleeding. So you should know that you have to change the plane and you have to see different one. In a specific strategy, also the use of the new technologies, the ICG is very helpful. We saw this together. Now surgical techniques. So you see this, there is a rectal nodule here, a big one, you will see it. This patient actually suffered from 6 years of primary infertility. She had pain, mainly it was the pelvic pain. So she came to us. Now I'm not talking about the rectal nodule because that's different. The disease was there. We are starting from here. So in a specific strategy of endometriosis, you have always to start away. So you're seeing that we are opening the peritoneum at the healthy side, identifying the landmark. You see the ureter. And then you go toward the disease. Keeping the ureter lateral. And then excising the diseased area. This patient had a successful pregnancy. She delivered spontaneous pregnancy, and this baby is now, I think, 1 year old already. Now, regarding if you have a torus nodule, you see that we are using here the monopolar hook. We love monopolar because it is giving a precise technique that you can do a very good excision. The only problem in monopolar is the smoke. You see that you have a lot of smoke, and no matter what, you will have some smoke, but still the vision is clear. The nice thing in the monopolars, you see that the first assistant is very active. Assistant is holding the tissue and giving a good traction. And this traction can help the surgeon a lot to be more precise in the excision. And you see here is the diseased tissue. How we know disease? Because still you see some brown color hemosiderin effect of the monopolar on the tissue. So here is healthy. we are starting from the lateral, from the healthy tissue toward the disease. We never confront directly. Risk of injury is much higher if you go directly toward the disease. So we are starting and then using the monopolar. Here is the monopolar scissor. And trying to excise as insano as possible. I will go because there is many videos. Now, sometimes we are talking that you have to be insano. What does it mean, insano? It means you have to remove all the disease part, be margin free, to remove as much as you can. Yes, we know this is not cancer, this is endometriosis, it's benign, but we know that if you are insano and you are doing a complete excision, your risk of recurrence is much less. So sometimes to be insano, you have to open the vagina. Is it a big problem? No. If you have to be complete, you can open the vagina, but of course, then we have to repair it. So you see here that still some diseased area at this level, and you can see the brown color at this level, so you know this is the endometriosis and diseased area here. Don't excise a lot. Be economic toward the tissue. You don't want to shorten the vagina and give her a bad sexual experience also, but and try to be complete as much as possible. So now, if we have a disease, as we said, that is it a big problem to do colpotomy? No, we can do, because we said that the recurrence rate is lower if you are insano and complete in your excision. So if we did colpotomy and open the vagina, which is the way to close? This or this, right or left? This? This? Okay, who said this? Who said this? All right. So usually we close in this way. Why? Because when you're closing in this way, and this is the surgical 101, that if you close in this way, you are shorten and tighten the vagina, which can cause more dyspareunia for the patient in future. So the transverse closure can give the width more when you're closing transverse, and gives the length of the vagina longer. And you will not cause shortening of the vagina, which will not be a problem for her sexual intercourse. You can close interrupted, you can close continuous, you can use barbed, but the most important, you should not be necrotic. So it should not be very tight, it should not be too much pulled, because you should not be necrotic toward the vaginal wall. Okay, this is another case. This patient was a 30-year-old, deep endo, retroflexion, deep pelvic pain, dyspareunia, all the typical pictures of endometriosis. We saw the MRI before. We see here I'm talking about the uterine plicature, or the retroflexion that we have due to endometriosis at the level of the torus and the uterosacral ligament. So again, the strategy is the same. We are trying to free this uterus from the plicature. We always start the same strategy, always. And then we go to the specific. Opening the plicature from the diseased area, giving the rectum to the assistant. You see yellow, 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 pink. So you go here. And then open, mechanical force, traction, counter traction. And try to go to the disease. Same on the other side, and then, okay. I will move for the next. So now the question, patient comes to you, she has the typical symptoms and signs of the endometriosis, the pain, the Ds, all the infertility, everything. But you do MRI and you do scan, you do imaging, and you see retroversion. Is every retroversion endometriosis? We have a problem with this also, because we are nowadays also having a lot of overdiagnosis of endometriosis. And we see patients that they come, yes, they have the symptoms, but they get a lot of overdiagnosis. It's not correct. So there is specific things that we have also to look into it. And we say pelvic congestion syndrome is underrated. That's why we specify a specific session in Endo Dubai 2026 talking about the pelvic congestion syndrome. I hope that you come and we can discuss it more. Okay, in this case, we have a retrocervical adenomyosis. You see the uterus, you see the adenomyosis at this level. So this is still in the posterior compartment. We are starting again the specific strategy. We are restoring the anatomy, identifying our landmarks. So we access the rectovaginal septum and space, and we are doing the adenomyomectomy at this level. Here with the adenomyomectomy, we are using the harmonic. I'm not discussing adenomyomectomy, we have a picture on that. This patient also had a successful spontaneous pregnancy after 4 years of primary infertility. This is the preferred topic of Professor Philip. He loves the pouching of endometriosis in peritoneum. So when you see this, you know this is endometriosis. These lacerations, pocketing, pouching in the peritoneum, we know that this is endometriosis. And they have normal clinical exam, maybe they have normal MRI, but they might have some infertility, they might have some symptoms, some pain. But if you saw it incidentally also in a laparoscopy that you're going for another reason, this is a sign of endometriosis. Now, if is every peritoneal endometriosis deep endo and it has to be excised or no? We say that deep endometriosis when the infiltration is more than 5 millimeter. Yes, that has to be excised. But if you don't see anything visible, you should not do general peritonectomy for everybody in this for this reason only. Okay. And we always say that it's a tip of the iceberg. So again, we are saying that complete surgical removal for the minimal and mild endometriosis improves the subsequent pregnancy, whether it is the IVF, ICSI, or spontaneous pregnancy. This is a retrospective cohort. When they checked 54 patients, they underwent posterior peritonectomy, and they saw the pregnancy rate after this was 46%. This is recent in 2020. This is a picture, a video of douglasectomy or peritonectomy for endometriosis. So we start with injecting vasopressin. Not every time we do vasopressin, sometimes just to have more plane and decrease the bleeding, but you can do without. Always from the lateral, go to the medial. You see here the assistant is using the suction device to try to decrease the smoke to give a better vision. The important in this, and all of us, we tried it yesterday in the lab and the day before, is the traction is very important to get a good energy with the monopolar. So you should have a good traction, try to excise precisely, to be more precise. Use of ICG in these levels is very helpful to see the ureter. Otherwise, if you don't see the ureter, you have to identify the location. So if you know and you see it and the ureter is away, you do not need to dissect. But if you don't see and you don't know where is the ureter, you need to dissect and keep the ureter lateral to your excision field. I will move it because this goes slow. Okay, so we are excising. You see the same technique, the same principle. Stopped. Be careful when you're reaching to the vagina. If the disease is not involving vagina, try not to open because you don't need to. It's stopping. And also we have to be as complete as possible. So what are the risks and the danger, the pitfalls of posterior compartment? Why we are talking about it, why we are emphasizing on it? We have a lot of risk associated at this level. We have the nerve, the neural risks. We have the cervical canal, bleeding, adhesion formation, the injury of the ureters, which is at that level, rectal injury, and uterine rupture. Nerve sparing is very important, and we are always advocating for the nerve sparing at this level. And specifically, you have to try as much as you can to try to spare the hypogastric. Here you can see in this video, this is what we are aiming for. We have a good dissection, we are trying to remove the nodule, and we are trying to preserve and spare the hypogastric nerve. Is it always feasible? Probably not, but try as much as possible. Because we know that deep infiltrative endometriosis, up to 40%, they're associated with urinary dysfunction, and this is because of the neural damage that happens at the level of dissection, which is happening. So prevention of this is very important. Many studies are saying that patients end up by self-catheterization, ureteric dysfunction, overdistension of bladder, and we are trying to be as much as possible economic toward the nerves at this level when you're doing the dissection. Our practice in our unit, when we are doing deep endometriosis, we keep the Foley's catheter till next day morning for 24 hours. And after that, we ask the nurse to start clamping the catheter. She clamps it for 2 hours. When the patient starts feeling the urge, we will open the clamp. Again, we clamp it one more time. She feels the urge. We need 2 urge of the bladder, the patients to feel it. So after that, you can remove the Foley. Don't remove the Foley directly because it can cause retention and residual urine for the patient. Another risk can be associated is if you go into endocervical canal, and this is a very difficult if it happens because it can end with a stenosis and further problem and more consequences for the patient. In this case, you see that we already had opened the vagina because of the disease was already involved in the vagina. You see how deep is the disease. But at this level, we will see now the cervix. So the cervix got cut. Here is the cervix. You see already the disease is involved. It's deep infiltrating at that level. So if we open the colpotomy, cervix should be one landmark for you also. Yes, we still have some disease here, but if we want to cut this, we will amputate all the cervix for the patient, and this is not feasible. So we try to remove the nodule and preserve the cervix. This is the cervix in the vagina. And this is the vaginal mucosa. Here now we are cutting the mucosa. Okay, if this happened, what to do? We leave it like that? Of course not. We have to fix the cervix back. And we do hysteroscopy. We need to do hysteroscopy because we have to make sure that there is no stenosis. We also bring back the patient after 4 to 6 weeks or even 2 weeks to do another office hysteroscopy for her, trying to avoid stenosis of endocervical canal. So you see this is the cervix, which was cut at this level. And then fixed again. There was no stenosis for this patient and everything was okay. Bleeding is very important. Of course, the venous bleeding is much more serious and much more difficult to control it rather than arterial bleeding. At this level, when you are at the torus and uterosacral, we have the uterine vein, but if you are on the lateral side, then you have the posterior trunk of the internal iliac. The vein bleeding is much difficult to control rather than the arterial acid. Now, uterine rupture also can be associated with patient who has surgery for posterior compartment. For example, in this case, you see this was a case series which was presented and published. They saw that patients were around 26 to 36 years of age. They followed them up to 3 years of the pregnancy. And the nodule size was up to 4 centimeters. The surgical device which was used in all the cases was the ultrasonic device. And the gestational age for the rupture was between 31 to 41 weeks of gestation. This was one of the MRI of the patients. And you see here, the nodule, or what we call it, the retrocervical adenomyosis, that can cause already problem in the muscularity of the posterior compartment, and patients can have uterine rupture and obstetric consequences when pregnant. So if patient comes with pain, you have to think of it if she has a surgical history of endometriosis. Bowel injury, if the patient is not well clinically, please do not hesitate to go fast for next step, either CT or go for a second look laparoscopy. Never delay, because we know that how bowel injury can be dangerous, and bowel injury is a side effect, is a risk. That risk can be associated in cases of deep endometriosis surgery. And if we did colpotomy, for example, and we did bubble resection, never leave the two sutured area, raw area exposed to each other. This was shown yesterday in the pre-recorded video that we shot. So we have a bubble resection at this level, we have a colpotomy here, so we have to cover the area. So the covering can be with the meso, sometimes also if you are not lazy with omentum. Don't keep two raw areas exposed to each other. You will have higher rate of fistula formation. So omentectomy and using the omentoplasty at this level is very nice. And for example, this patient, if you do rectal shaving, do you leave it in this way? Or what should we do at this level? If you leave it in this way, you can also cause decreased vascularity and it can cause exposure and fistula formation. So what would you do? Would you close and let it be? We will close, say it, we will close. So you see here that we already have done rectal shaving, we have reached up to the serosa is gone, the muscularis part is there. So we are trying now to suture back the serosa part of the shaving. So you can sleep better at night when you do the surgery. And for the ureter risks, yes, we always look for the peristalsis of the ureter at the end of the surgery. But just having the peristalsis, it does not mean that you did not cause a thermal injury or there is no injury on the ureter. Best evidence to make sure that you are safe is cystoscopy. And in the cystoscopy, we have to see the jet and the peristalsis. Having these two will give you more satisfaction and more reassurance that we are good toward the ureter. However, if you see, for example, sometimes, sometimes there is discoloration of the ureter and the ureter is becoming devascularized. It's not wrong to put a stent intraoperatively and follow up the patient. You see here the color is different. You see it's more like the adventitia of this ureter is not as preserved at this level. So at this point, it's not wrong if you put a stent in the ureter intraop. And adhesion prevention, of course, during surgery, at the end of surgery, after surgery. During surgery, we have different detailed lecture on it, but be antiseptic, good hemostasis, soft tissue handling, and try to not to be very tight in the sutures. 80% of adhesion prevention is by good surgery and good techniques. The remaining goes on the barriers and the different devices and different products which is available in the market. So here you see that usually after each endosurgery, we do kind of adhesion prevention. We use powder, we use a spray, gel that can also help, also Springer lactate. And after surgery, do not delay the patient's drinking and reelimination, early mobilization, and high quality of analgesia so you can help the patient to mobilize faster. In a nutshell, we say that be radical toward the disease, but be conservative toward the function of the organs, and always respect what your patient wants. Don't forget, this is a benign disease. They are very young patients. They are fertile, and they want to preserve their fertility. And don't undertreat and don't overtreat. I would invite everybody of you to come to next Endo Dubai. It would be loving to have you here and see you there. And this is a barcode for the different master classes and the courses that we provide in Miss Academy. You can have it and look into it. Thank you.
Thank you, Zainab, for this complete lecture on the posterior compartment. Any question? Yes, we have one.
Thanks for the lecture. You mentioned that we also have overdiagnosis of endometriosis. I think I can agree on that. But back in the years, we had underdiagnosis of it. Now we're at a stage of you don't see deep endometriosis, but the patient has a FAS score of 9 dysmenorrhea. She can't go to her work for 2 days and she faints when having a period. Then we say in our clinic it's most likely that you have superficial form of endometriosis. This could cause to overdiagnose, I think, but how do we handle these patients?
Yes, exactly, because the symptom-wise, they can be the same. The symptom can mimic each other. But we have the clinical exam, and what we do in our unit is that we do MRIs. We look into MRI. In MRI, if you have endometriosis, superficial endometriosis cannot cause this kind of dysmenorrhea. When you have dysmenorrhea at this level or pain at that level of pain score, you should have deeper infiltration of endometriosis where it can be visible on MRI. However, still, if you are not very accurate, and I would really advise that you look into your MRI yourself. Don't see the report, see the images, start looking for endometriosis in different sections. And if still you are not satisfied or you are not sure about your examination and your imaging, you can put her on a challenge test. It's a treatment in the same time, also diagnostic. Put her on suppress her ovary, block her ovary for 3 months and see if the pain decreased. This is a sign that maybe this can be related to the endometriosis. If the pain didn't, put her on, for example, pills and block it for 3 months and see. I think this is the way we do. Yeah.
And sometime, whatever people say, we finish to do a laparoscopy.
Yeah, at the end if needed.
More question? Yes.
So specifically for deep infiltrating endometriosis, especially, when there's a lot of fibrosis, sometimes it's really hard to take out all the tissue. What do you see of your risk of recurrence in your population and repeat surgery?
We don't have the data. We don't have the full data. We do a lot of endometriosis, we should have, but we don't have the data of the recurrence rate. But we follow up our patients a lot. And yes, we have some recurrence. I cannot tell you exactly how much, but generally we are very good and very good to the patient's pain, and we have a lot of fertility good outcome for that.
Yeah. Do you put?
Hopefully, we will prepare the data.
Yeah.
But yeah, you have to separate the recurrence rate of pain and the reoperation rate, which are a little bit different. Recurrence rate of pain is obviously higher than the reoperation. I think reoperation we are at 6%. 6%, which is quite high still, but it's okay. But we have much more recurrence rate of pain that we treat medically. And so I think that this is the issue. If you have recurrence pain or remnant pain post-op, the first line therapy should be medication.
Correct.
So,
Do you put your patients, for patients that don't necessarily want fertility right after surgery, do you put them on short-term hormone therapy for 3 to 6 months?
Yes, we do sometimes. Depends on the activity of the disease, the situation intra-op. But if she's not looking and we saw that it is a kind of active endometriosis, yes, we do.
but we have the data for that. So
Yes.
if the patient is not looking for immediate fertility, it's better to block them at least, to block the ovulation at least for 6 months.
Yes.
And if you do so, you reduce the rate of recurrence. Virtually.
Yes.
Okay, last one, because then Alberto, let's go ahead.
Does treatment of deep endometriosis improve live pregnancy rate?
What? I couldn't.
Does treatment of deep endometriosis improve live pregnancy rate?
Pregnancy rate? Yes, it does improve. Many studies has already proved. I showed some studies that
Yeah, you have studies,
Yeah.
but there is no
in real time.
randomized control trial. There is no guideline to say that treatment of endometriosis improves pregnancy rate.
What treatment you mean? Surgical?
Surgical. We have studies.
Okay, we take expert
But
opinion, Prof.
we have a lot of, the problem, that's why the talk of Alberto will be important now, because, okay, if you speak about fertility, you have the spontaneous fertility, you have the spontaneous IVF fertility pre-op, and then you have failure, and then you have fertility after surgery. And so that's why the data are a little bit complex together, and I think that maybe Alberto will talk about that. But in our experience, when you see this patient, for example, this patient has 6 years of infertility and failure of IVF, and then we operate her, and she got spontaneous fertile.
I totally agree, but it's not a statement. it's an experience.
No, but it's not a statement. I think this is what I said on Monday. I think we don't have those trials that they do in oncology, and we should. But my intimate conviction is that we are quite efficient. And if you look in our theory, we have more than 60% of fertility global, IVF plus spontaneous post-op. And most of them were infertile or were in pain. So that's why we also have to divide the group.
Thank you.
Alberto.
Thank you.
Thank you. This is for you. Alberto.
Thank you, Prof.
So about the IVF role.
Thank you for inviting me and giving me the opportunity to speak about fertility. Let's see. Okay. So, I don't have financial conflicts of interest, but I have some. So I work here, very big, a group of fertility, probably the biggest in the world, in number of clinics at least. So I work with IVF people. That is not easy. I learn from him, so I love surgery. So these are my conflicts, okay? And we have an infertile patient with endometriosis. I'm going to speak about that, okay? And we have some factors that can influence in the decisions we make daily. 4 things: the evidence, the IVF, the surgery, and the industry all make an influence in our decisions, okay? In the middle is the patient. Usually it's an infertile patient under 40. I'm speaking about what we have in my daily practice, okay? Probably it's not yours, I don't know, but I speak about my experience. Under 40, seeking for babies, and sometimes with pain. So what we do? We follow the priorities of the patient. So the patient comes to the clinic. If she has no pain, the priority is clear, is babies. If she has pain and she is alone, the priority, remember, she's coming to an IVF clinic, okay? Fertility clinic. The priority is babies. If she has a female couple, priorities usually are babies, even with pain, I'm speaking. And if she has a husband, even despite the husband is telling her, look, our intercourse is a disaster, you are not in a good mood because you have the pain, so come on, let's go for surgery and improve your quality of life. And the priority, at the end, you will know, is the same, is to having babies. Why? 2 reasons. This is probably, I think, the most powerful desire of a woman in her life. Probably, I think. This is the first reason. And then, this is the second.
Let me just say to the men in the room, this is important. A marriage is a great continuing relationship of conversation and convictions and opinions. And in those conversations and convictions and opinions, one person is right, and the other person is called a husband.
So, it's like that. When you have a couple, the female couple, the woman has the reason, and if she wants to have babies, even the husband tell the opposite, you will go for that, okay? What is the evidence we have? So speak seriously about that. I put this always in the presentation because I think this is the perfect article for me. And look how it is. They did that. Nothing to do with endometriosis, but I will speak about that. A woman with polyps and undergoing intrauterine insemination. 2 groups. In one group, they did an hysteroscopy, okay? They did a biopsy of the polyp, they leave the polyp inside, and then they intrauterine insemination. And in the other group, they did hysteroscopy, they removed the polyp, and then they look for the results. This is a randomized prospective trial, very well designed. And the results are that pregnancy rate is higher when you remove the polyp. So it's clear, okay? Do we have something similar in speaking about endometriosis and fertility regarding surgery? This is the only thing we have. Randomized prospective is very old article, okay? but it was very good, very well designed. It's for minimal or mild endometriosis. This was made in Canada. Okay. Philip doesn't like this, but okay, I must tell because it's the only we have that is randomized and prospective. Okay, what they did, two groups. In one group they did a diagnostic laparoscopy. In the other group they did a laparoscopy. They removed endometriosis lesions, and then the pregnancy rate after 20 weeks was higher in the group where they did the laparoscopy, removing the endometriosis. Okay, this is done by Sylvie Marco, that was the epidemiologist, and of my, that he was the gynecologist, is here in the middle. I was with him in 1993, 4 years before he published. He was working on that, I remember. Unfortunately, he died some years ago, but he was really a very smart guy. So this is what we have. Don't we have any other evidence? We don't have. This is always the same. Endometriosis associated infertility surgery or IVF. This is the summary of every article speaking about that. Due to the lack of solid evidence in the scenario of endometriosis associated infertility, robust data from randomized clinical trials are strongly needed. So we don't have, okay? It's only the experience are retrospective and many factors. This is other factor that influence in our decisions, okay? We have a surgeon doing surgery. What do? We have this frozen pelvis, already spoke. We should do a laparoscopy, never laparotomy, never. No indication, okay? Because the vision is what we have. We take better decisions, we are more precise, better results. It's like that. And we know that surgery is very good for pain. This we know it, but is good for fertility? What do you think? So, surgeons like to cut. This is like that. You saw it already. So what happened? I will speak a little bit about the ovary. Okay, so you have this frozen pelvis. You have, imagine a bowel involvement. You have the ovaries there. You have the nodule in the rectum or in the vagina, whatever. What do? You start the surgery, you freeze the ovary, you break the cyst usually, and you suspend the ovary 2 or 3 hours if you are a good surgeon, perhaps 5 if you are not so good, to the abdomen. Okay? You do the surgery, very nice surgery, but when you end, you are tired. And then what do? You do the cystectomy, okay? If it is worse, probably the fellow will do it, or worst, the resident. It's okay. So what happened? You decrease, the ovarian reserve. You can be the best, but you will do that. We have proof, okay? After surgery, the AMH levels are significantly reduced after surgery. So what we do regarding the ovary? What should we do? We must be smart. So first, don't touch the ovary. It's like that. And second, if you decide to touch, freeze the eggs before doing that. This is a very good advice, okay? Because you are going to decrease the reserve of the woman. And they are delaying fertility. And when they come to you, they are not 30. They are 37, 38, 39. I'm speaking about fertility clinic, okay? Then what do we have? We have the IVF clinician making decisions. Do they like surgery? They don't like surgery at all. I work with them, believe me, it's like that. They like embryos, they like oocytes, they like to run because the patient wants to have the babies very soon and they really love ultrasound. So how it is? And look, they come to you, the amount of papers is like that because they explain everything. 10 years, 5 years with infertility, we went to this clinic, we do this cycle, we had, oocytes, the embryos, the sperm, whatever. And after speaking 30 minutes, what do we do? What do? They do an ultrasound. It's like that. And they forget to do that. And this is a pity. Because they don't do the exam, they don't put the speculum. And this is not right. They should do it, but they don't do it. Because if you find this thing, this is a very old video, it's 2010, 15 years ago here in Strasbourg. And if you see this very nice image, this is pathognomonic of endometriosis. If you see that and you remove the pain of the patient is going to improve a lot. And I really think that Probably that is underestimated is the factor of intercourse when you come to a fertility clinic. And if you have endometriosis and you have dyspareunia and you remove this, spontaneous fertility is going to increase. I don't think we don't need the evidence for that. But it's underestimated because couples, they don't speak freely about that. And we should change a little bit. And IVF clinicians, they really love money. Many of them are rich. Unfortunately, Chuck is not here. He's a good proof of that. But where is the money? The money is here. And this is important. Is the reality, okay? Look, if you have the opportunity to go to an ESRE, every one of you have been in an ESRE Congress or ASRM Congress? No. This is amazing. Nothing to do with ESG is 2,000 attendees, 30,000 if we are generous. But if you go there, you cannot imagine what is that. It's crazy. It's 10,000, 12,000. And why? Because the money is there. It's the only reason. It's not for other thing. And if you see the stands they put, this was in, I don't have the data of the last two congresses, but in 2023, the stands, they are related, these ones are related to hormones for stimulation, culture media, material for transfers, pickups. And look, the ferrin stand was 243 square meters. It's amazing, much bigger than my house. But the stand of storage in this Congress was 18 square meters. 18, 1/8. It's nothing. So surgery for fertility people is not important. This is the message. So the scenario is, okay, we have a young woman wishing babies, a woman who doesn't want to be operated. I tell you the reality is this thing, okay? Probably yours is not the same, this is mine. Despite pain and despite the clinician doing IVF, we have the IVF clinic and pharmaceutical companies making the pressure to the doctor to earn money, it's like that, and we don't have evidence, this is very sad, supporting surgery to improve live birth rate in this infertile woman with that. So, what we do? We should change this. How? We can publish, it's the best way to do it. Very difficult, but you know, this article changed something. So we can do the same with regarding fertility and surgery. We can be creative doing, like Harry Rich, the first laparoscopic hysterectomy in 1988, good option. Or like Anna Cobo, the first live-born baby with vitrify oocytes in 2007 in where I work, is an option. So we should think. And I'm really happy because one of the things we can do is to decrease because, you know, if we don't have data and we have this endometriosis surgery, it's very risky and very difficult. What can we do? We can decrease the rate of complications. I'm very happy because I saw this reinforcement, not to reinforce the anastomosis, to decrease the tension. This is really smart. Put this meso there. So this decrease complication, this is something, this is important. So if we do that, we can do surgery with more confidence, because complications is the problem of this surgery, okay? So this is good. Do we have any evidence that if we train people, we are going to decrease complications? We don't have the evidence, but we know it's like that. We believe on that, okay? And it's important also, don't be selfish. So you must share your knowledge. This is important, because if you educate and train, you will improve the things. I like this conversation. Look, this CFO, the financial officer, as the CEO. What happens if we invest in training and then they leave us? And the CEO answers. What happens if we don't and they stay? This is much more important. So don't hesitate to train people, okay? What can we do? We can tell Storz and Medtronic to put a big stand in the ESRE Congress. So we will have visibility. This is an option, but the best we can do is to publish that. It's fake, but DICE surgery improves live birth rate before IVF compared with IVF alone prospective. This could be interesting, and we have two bigger studies working. This is the French one. We don't have the data now. Waiting for that. Is bowel endometriosis, 2 arms. One is surgery, and then spontaneous pregnancy or IVF, depending on the EFI score. I'm finishing. and the other arm is what I said is surgery, and then the IVF, or the other is only IVF. Okay, let's see what happens. This is a study. I don't like that much. I prefer this one, the Italian one, because it's clear. It's more clear. You have one arm is a woman under 40 with deep endo involving bowel. One arm is surgery and then spontaneous pregnancy, and the other arm are 3 IVF cycles. They are going to look for live birth rate and the cost of both arms. This is very interesting. No data by now. So to conclude, what we know that surgery is good for pain. This we know it. We know that surgery is recommended in minimal or mild endometriosis. Even Philippe tell something different, let's see. As increases spontaneous pregnancy. In case of infertility, this is the most important message for me. As DICE surgery is risky and difficult, and we don't have strong data supporting it for improving fertility, I would recommend IVF. We don't have the data. In cases of pain and infertility, we follow the patient priorities. And to end, we know that surgery is supporting actor in fertility, it's like that. They don't like it, but some supporting actors are extraordinary. So if we do it right and we believe on that, we can have as proof good results operating the patients that seek for babies. Thank you very much. Any question?
Thank you, Alberto, for this. I love this lecture always. Any comments? I think maybe no question, but any comment?
We are on time.
Philippe, I know you
Philippe,
want.
come on.
I know you want.
No,
Tell me.
it was a very nice presentation. First comment. Yeah, I like that.
Thank you.
The second thing is that this is the whole area of infertility is the area of how to lie with statistics. And because they want to do randomized controlled trials. Now, one of the last papers which we wrote together is to say it's impossible to do a randomized controlled trial because all this fertility is multifactorial. The age of the woman, the duration of infertility, the two important factors, the male and so on. You cannot randomize for all, which means that because in a randomized trial, you can have one factor, maybe two. If you have 3 or 4 factors, you have so many groups, you cannot randomize. And this is the problem of infertility. What I think about fertility and endometriosis, first, there's no evidence whatsoever that endometriosis impacts fertility, unless it's something which is there before puberty already. The superficial endometriosis, it's clear. We wrote once upon a time one of those Ukraine. This was retired because the data not there. What you have with Marcou trial, the IRCAD trial, what they did, they randomized, they did it well and so on, and then after surgery they said to the patient, you have endometriosis and you still have it because we didn't treat it. And then you see that the pregnancy rate in that group, which still have endometriosis, is half of what we normally have if the normal is 30%, they get to 15%. We wrote that once upon a time, this is probably luteinized and ruptured follicle syndrome. People get nervous and do not ovulate. But I did like a lot your presentation. This is reality of IVF.
Thank you.
But we have good messages. Huh? One, as he said, we are efficient on pain.
Yes.
And
And so
clearly,
if pain is priority, no
This
problem.
we know.
Then the second problem is the importance of egg-freezing, I think before surgery, and to be early for offering that, because you have seen the number. Huh? If you pass 34, you have a decrease of efficiency.
Yes.
And then the main question for me, because honestly speaking, I would love not to operate those patients. I would love to not operate those patients. Now the question is, and as we have a high volume in Dubai, is that we have seen a lot of complications on IVF that are never described by IVF center.
Yeah, and not
I can
even
tell you, we have had infection.
even in pregnancy.
Eh? And so I mean the situation is not that clear, and that I am afraid that what you said is true, that it's quasi impossible to have a randomized trial. I think.
Yeah.
And also, for instance, one of the things which is hidden, the IVF, that's why the IVF people are very intelligent, but liars by definition.
I have a question.
Because
Well, I think that maybe we can continue to have discussion during the live surgery eventually, because we
Can
should...
I ask a question, please,
Yeah, no,
to
no,
Alberto?
we ask a question in a minute. Because I think, give me a minute, Pascal. Where are we with the live surgery? Because they are waiting, you see. Then we ask the question, okay? We start with whom? Philippa?
Good morning.
Hi, Philippa.
Hi. Can you hear me?
We hear you very well. We see you very well. Good morning, Sonia. How are you? The dream team. Okay. And on the other room, we have Elder. Okay, whatever. Elder is putting ICG by cystoscopy, as I see.
Yeah. We are starting, but I can show you from now the nodule. You see?
Yeah.
This is the nodule. I showed you the slides. Maybe you can present to the people over.
We are going to present, but I just wanted to show the people just one side, and then I come back to Philippa, if you authorize me, Philippa. Just want to show the people the cystoscopy and how we put ICG in the ureters, because it has been asked yesterday. So just one side, and then we move to Philippa, and then we will show. So you have a beautiful nodule in the center, so going down to the trigone, so it's nice. When you want to easy do that, don't fill up too much the bladder.
Yeah.
If you see what I mean.
We are just.
If you fill too much the bladder, the urethral MEA goes down. So you can lose it. So you have to decompress the bladder. So here is a bit too much, but then you follow the treatment. So at the same time, on the other screen, we can see the story of the patient. If we can come back to the first officer, 2 years, newly gravida, primary infertility, catamenia matura, dysuria 9 on 10, dyspareunia 8 on 10, and so you have seen the nodule. Aki, yes. So you see that when you deflate a little bit, you see the MEA comes back. Yeah. So I just tell you this because I don't know if you do a lot of cystoscopy, but I do, and sometimes we are struggling to find the orifice. Then you put this catheter, and
we go just 4 centimeters.
Yeah, 4 centimeters about. Theoretically, you have a mark, and then you inject 2 milliliters. Okay. And you will see when you go back, maybe some reflux of ICG.
Yeah, what we do is when we are almost leaving, putting it out, we ask the nurse to aspirate a bit to avoid contamination of the bladder. But in fact, in this case, to have the bladder fluorescent is not so bad, because it gives us anatomical information of bladder limits. But now I ask the nurse to aspirate a bit to avoid the spillage of ICG.
Okay, perfect. So now you do the second side. Maybe we can go to Philippa.
Yes, because we will put the catheters here on both sides, and then we will start by laparoscopy.
Okay. So let's go to Philippa now. Philippa, you are on screen.
Good morning to all. It's a really pleasure to be transmitting from the Hospital da Luz to you. We have a patient of 33 years old with primary infertility of 6 years that already performed PMA with 3 cycles and 3 transfers negatively. She has complaints of dysmenorrhea 9 through 10, dyspareunia and dyschezia. And on the ultrasound and MRI, she presents retovaginal nodule of 4 centimeters. And maybe if we can show in the screen the ultrasound, you'll see the image. You are seeing inside just during the preparation of the audiovisual team to show you the ultrasound. And you can see on the back of the uterus, we have a 4 centimeters nodule. So if we go to the inside image, so we can see the uterus, and by exploring the abdominal cavity, we have superficial endometriosis in the front side. And if we go to the back, you can see all the retosigmoid colon attached to the back side of the uterus and the left nexa. So as Professor Matias explained you yesterday, we generally start this kind of surgery on the left side by the mobilization of the sigmoid, and ideally staying above the white line. So I will free the sigmoid, attach my small movements. You see here the white line, and then you have a gray area, and that is the place where you should go inside to separate and mobilize the left colon. So you should stay almost above the yellow fatty tissue to go inside in the correct plane. Do you have a good image on our screens?
Yeah, everything is fine.
Yeah, okay, perfect.
Question, you put ICG too, huh?
Yeah. Can you see it? So we start the procedure by a cystoscopy, and you can see exactly where is the ureter.
Did you do an MRI to this patient or no?
Yes.
Okay. So quality of picture is fantastic. So it's very good.
Good.
Alors, all of you, you can ask direct
So
questions.
if you look to the pelvic side also, you have the ureter here, and then we have the yellow fatty tissue. And if you look to the pelvic side, you can see, let's say, more white and then yellow. And if you want to go inside the perirectal space, you'll have to go in between both. That means that you get inside the bubbles and the avascular plane. We have the left ovarian cyst that is impairing our vision. But if you see that we stay with the fatty tissue close to the bowel. And if you get inside the correct plane, you'll have all the nerves attached to the pelvic sidewall. So as the ovary is falling, I'm going to suspend the ovary with a T-lift. Just going to mobilize a little bit, breaking the cyst. And I will suspend the ovary with the T-lift. I don't know if you all know the device.
If what, sorry?
If you all know the device, the T-lift. I know you
Yeah.
know.
Yeah, I know.
Because you invented it.
I know.
So I'm going inside with the needle. I will cross the ovary. I will put inside the tip.
Yeah.
Bring the needle out, and that means that I will can attach to the abdomen of the patient with this blue device.
By the way, as we are here,
Can you see it?
Alberto told us, I didn't understand if
Okay.
it was not good.
We're just going to clean the image before going inside, but with this device, it's really easy to suspend the structures and to improve our vision. So right now I have all the parietal space on the left side developed. And I know that in the middle, I will have my nodule. So I need to get more information on the right side, and I will do the same. So if we look to the pelvic side wall, with the green, we will have the ureter, the hypogastric artery just below. And if we go to the middle, here we will have the inferior hypogastric nerve, and then it starts to be more yellow. And if you go inside there, that will be the correct place again to develop the parietal space on our right side.
No, don't do that. Okay, I would like to, we keep you on the screen, but I would like to go to Elder because I think he's waiting.
No,
So,
Okay.
no, we are just. So first of all, I'd like to say good morning to everyone. Bom dia from Porto University Hospital. It's a great pleasure. Thank you, Professor Vatier, for the invitation. We have here a big team involving the residents of the department, some fellows from Albert Einstein in São Paulo, from Firenze in Italy, and also we have the urologist in our multidisciplinary team. So we feel very honored to join this endometriosis IRCAD course. I told yesterday during my lecture that IRCAD has been my school, but my master, my professor is you, Professor Vatier. So I'm very happy for sharing with you this experience. We try to find a different case because we are, as a referral center, we receive patients from different parts, and this is a specific case with posterior compartment, but mainly anterior compartment disease. I'd ask you to present the slides if possible. I share with the audiovisual team over there. It's a disease that affects the anterior compartment. She has dysuria, she has catamenial hematuria, dyspareunia, and infertility. She is 32. In fact, if you move to the next slide, in the exam, we found induration in the anterior vaginal wall, and in the uterus there is a diffuse adenomyosis, mainly in the anterior uterine wall, in the isthmic part of the uterus, and this adenomyosis continues in the bladder, causing the infiltration of the serosa, of the detrusor, and also of the mucosa of the bladder, as you have seen before by cystoscopy. I ask you to move to the next slide, where is possible to see the nodule in the bladder. In fact, he has around 4.5 diameter maximum, but by 2.5. but also she has adenomyosis, and also she has some endometriosis in the uterosacral ligaments in the posterior compartment. I ask you to move to the next slide, and here you can also see that the disease infiltrates a little bit the uterosacral ligaments, and also in this anterior compartment it's possible to see that the anterior vaginal wall is a bit infiltrated.
And there,
Yes?
if we can, if you can, you go, you finish, you go inside or no? Because
Yeah, we are just finalizing.
we have
the
two
we need
screens,
like
so I have to manage.
5 minutes.
I have to manage the two screens. So
Yes, please.
So-
Better to go to Philippe, and in 5 minutes we should be inside.
because I see that now you put a double G stent.
Yes.
Okay, fine.
Because according to the radiologist and the urologist that sent the patient to us, the distance between the meatus and the disease was 1 centimeter, 1.5. So together we decided to put the stents at the beginning of the case.
Yeah, I think this is quite prudent. Let me go a little bit because Philippa is already dissecting the nodule in the rectum, and I come back. You are in the screen, so I follow you, okay?
Thank you.
Philippa?
So you are back with me.
We have seen that you have dissect both sides, and then as the technique described, we try to narrow the central adhesion to cut, and you progress like this.
Yes, so I have normal tissue on the right side, normal tissue on the left side, and like that, Sonia will mobilize the bowel towards the patient head, and you can see that we can identify in the middle zone the nodule.
I forget to ask you, you have a visible nodule in the vagina or no?
Not much, but you can feel on the right uterosacral ligament like a small bump. I think I will have to open it, but not huge as I thought it to. Well, it's mostly inside the abdomen.
So I mean that for the people here, you have two techniques. And the techniques that Philippa does, so she shave at the edge of the bowel wall, or you have the contrary, what we call the reverse technique. You can leave the nodule on the bowel and go in the vagina. And so, I prefer this technique because I'm used to it, but some people prefer to do the opposite. Okay.
And you see, when we have yellow tissue, that means that you are in the correct way. And I'm developing step by step on both sides. And again, in the middle, I will.
Philippa.
Yes?
Do you think a rectal probe helps or not?
Well, honestly, it will decrease my space inside. And only if I have doubts, I will use it. But if I have my correct landmark, so I have fatty tissue on the left, fatty tissue on the right, fibrosis in the middle and the nodule, I prefer to go like this without the probe.
No, she said no, but she feel it. I mean, and like Philippa said, you have people that put probes. And as our technique is based on the recognition of the anatomy, the problem of the probe that he fill up the space. And so here it's better to not use a probe because then the rectum falls. So you have a space between the vagina and the rectum itself. And only if you get stuck and you don't know where to go, then we put the probe to identify the space.
Only if you lose your landmarks, then sometimes I need it. But most of the time, I prefer to go only like this. And you see that the nodule is getting attached to the vaginal wall. Here you have endometrial glands in the bowel wall, in the rectum.
You plan to do a discoid or just a shaving? What is your plan?
I know that was a previous discussion with the patient, and the patient really prefers not to move for bowel resection, knowing the risks and the risk of recurrence if we let some disease attached to the bowel. But she prefers a shaving than
And so,
bowel
just
intervention.
for the sake of knowing how it's organized, what kind of consent you have for this patient? For example, you have she
knows everything. She knows that bowel intervention is always a possibility. And also, be careful. Right. She knows also that the shaving has risks, including rectal fistula and peritonitis after. Anyway, we know by the literature that when you perform a rectal resection, you will have an increased risk of complications. And she's really afraid of bowel intervention, and if possible, she prefers
Philippa, good morning. It's Pascal. I have the feeling that it's very difficult to give that choice to the patient because when they say that they would prefer not to have a bowel resection, somewhere that means that the disease is not so heavy and it's something lighter. So when you are sick and you are infertile, in your mind, you prefer not to be sick or less. And so it's difficult to have objective decision. You understand what I mean?
Well, of course, the patient tends to follow your advice. Wait. But I think we really have to discuss with them all the possibilities.
Yes, for sure.
And
to say that sometimes
even she knows that rectal resection is a possibility.
Yes.
She asks, if possible, not to do it. So I will try to perform a shaving.
But I think the problem here, as you see, is probably not the bowel, but the pelvic side, the right uterosacral ligament. Let's move. We keep you, Philippa. It's beautiful job. We go to Elder now because he's inside. Elder.
Hello, Prof. So we are inside. We put the double J stent. We put the ICG on both ureters. You can see. In fact, we started to use it since long time ago, and we use it in a standard way. And it's helpful to give us a mapping and the pathway of both ureters. But you see, mainly in this case, the disease is here on the anterior compartment. She has this tube with this adhesion there, some endometriosis over there. But I think at the moment we will start by the anterior compartment, and then we will move to the posterior compartment. Tell me, how is the picture over there?
Picture is fantastic. No problem.
Okay, great.
Thank you for the case because it's good to have a quasi single compartment. So that will give us some clarity in in the transmission. So we have the posterior nodule with Philippa, the anterior nodule with you. So I think we couldn't dream to have as good things. So
Yeah, when I saw the topic I tried to find this case. So as it was discussed yesterday and presented very well by Anastasia, we will follow the same strategy we do in the posterior compartment, as Felipe is doing. We start by lateral to central. We start by opening the lateral spaces, and here in the anterior compartment, the lateral spaces are the paravesical spaces. We know that there is the medial paravesical space and the lateral paravesical space, and we will go medial to this structure that is the obliterated umbilical artery, because it's the medial paravesical space. We will open here, we will open there, then we will isolate here the nodule. Of course, we will open also a little bit here in the anterior part to delimitate the nodule, and we will try also to dissect this area. Here we have seen in the MRI there is some adenomyosis. We will see what we can do. She has no babies. We have to preserve this uterus. And also we will try to understand about the vagina. That is an advantage of laparoscopy, is that we can palpate the vagina at the same time. But here the beauty of laparoscopy and of endoscopy, we have these bubbles. We have this champagne effect that has been taught to us by our professor Arnaud Vattier. Just a few words about this device that we are using in the central port. This is the new LigaSure XP. In fact, it is a little bit longer than the normal one, the normal Maryland one. It allows us to perform probably a better dissection, and it rotates 360 degrees, like you see. So it's an improvement, a clear improvement in comparison with the previous device. Of course, we can use a simple scissors there, but I wanted to show you this sealing device, this improvement in the system. Well, as I said, we open this paravesical space. We try to go deep. I'm operating with Miguel Ramos. Professor Miguel Ramos is a friend, and in fact, is a urologist from our department. Also, I'm operating with Luis Castro, that is manipulating. He is using the Tintara uterine manipulator. And also we have here all the team. We have Sandra Maya as nurse. We have Zé Carlos as anesthetist. It's a super team, I should say. So after opening on the left, we delimitate here the disease. We go to do the same on the right side. We can use the LigaSure to do this. So we can use also simple scissors, and with the technique of opening the spaces. This Hobby Kelly I didn't mention, but I think is like the main tool of our endometriosis surgery approach. It is a very good dissector, very strong, and also very precise bipolar that allows us to coagulate immediately these small vessels that we have in the way. And the beauty of laparoscopy is trying to keep our surgical field dry without blood, because we know that the red of the blood interferes with the quality of the picture. This is an interesting thing. You see, if we go closer with the scope, we will see here the fluorescence. This is why I told you can be interesting to put some ICG inside the bladder. It gives us real-time information, as you see, about the bladder anatomy, the bladder limits in this way. I'm also trying to isolate a little bit the bladder in this anterior part. Probably we wouldn't need to be so I should say, dissect so much, but anyway, I think having this anatomical information gives us some safety when we will go directly to the nodal afterwards. Here we are in the right medial paravesical space, medial to this. Let's see.
Elder, we keep you on the screen. I go back because we are close to the innervation with Philippa, so I would like to ask a few questions, but we keep you and we come back in a minute. Okay.
Okay, thank you.
Philippa, Philippa.
Yes, can you hear me?
Yeah, we hear you. We see that you have dissected fully the space now. We have seen that at some point you have used those.
We have the rectovaginal space completely open. You see here the posterior side of the vagina that is clean of disease. And we have disease here.
What is your strategy towards the nerve now?
Well, on the left side, it's easier because I only have the upper part here involved. On the right side, I have the right hypogastric plexus affected. So I will try to be as superficial as possible, but I think I will have to shave a little bit of fibers on the right side. So I will try to spare the left, and I will be a little bit more aggressive on the right side because it has more disease. Okay?
Okay.
So
can you show us, as you do, as you have put the ICG in the ureter, where is the location of the ureter? Because we don't see the green here.
It's here.
Here. Yeah.
So I already put the ureter on the sides, on both sides.
No, it just, because this one seems to be a little bit, Okay, so fine. Perfect. Okay, so we look at you, and I look at you shaving this, and then
I'm having a problem with my monopolar hook, so I have to change.
Me too. I always have problem with my.
Not working. But we can move to Elder, and then you can.
Yeah. We go to, but we are. You're on screen all the time, so I follow you. Let's go to Elder for a minute because he's attacking the nodule frontally.
It's very nice to be operating together with Philippe on the other side because we are very good friends. We also learn with you in Strasbourg and Portugal. I think it's a small country, but with nice people. So now I'm trying to go in this space between the nodule and the uterus. We can see here the adenomyosis.
I have a question, Elder, for you.
Yes.
I think that when you are in the right here, exactly where you are, but maybe probably a little bit more dorsally, I think you can probably go to the vagina. Do you not feel that it will be interesting to go to the vagina on both sides, caudal to the lesion, before to separate? I mean, more caudal because here.
Yeah. I think.
The same thing we do with C-section,
Yeah, I think can be interesting and useful also to see how the vagina is infiltrated and affected by the disease. Okay. Here on the left side, the nodule is more lateralized on the left side. I will try to dissect a bit here. Try to find the. You see, even with this sealing device that gives us this versatility to coagulate and cut. I think we can use both hands. We can be ambidextrous. But also I like to use scissors, like okay, I think okay.
Alors, we were discussing with Philippe here. Why do you free this anterior aspect? For what
Just
is
for anatomy and try to. There is no need. I agree with Philippe. Greetings, Philippe. But you know, sometimes we like to see all the anatomy. I will ask a suction irrigator. I will ask Luis to push cranially the uterus, try to understand better this situation here. If the MRI is correct, this should be the real size of the nodule. Quite big.
Now we can cut this.
I will.
Okay, we follow you. Then let's move to Philippa that start the shaving the torus. Philippa?
Okay.
Yes, you are back to me?
Yes.
Right. So if we look on the left side, we clean the nodule and it's attached to the posterior side of the vagina.
Mhm.
And now we were moving to the right, trying to be
So you see,
as conservative as possible.
yeah. Now for the people you see here, this is the beauty of monopolar. Look the difference between this, which is pink, and this is yellow. I mean, because this is the seed area inside the endometriotic tissue.
I can't hear you. I'm sorry.
You hear me?
Now, yes, but before, no.
Yeah. No, I was explaining here, you see, why I like, and it seems to be you like the monopolar is because of this. You know, here, you see that you
Because you can draw the lesion.
So you see the limit of the lesion. So here you have a little bit more. There's no need that you have to remove it eventually. You can just coagulate.
You see that I have the lesion on my bipolar, and you see almost the correct plane and the bubbles, and the nodule is getting free from the backside of the uterus.
So she will see it. She can see. Yeah. You see the disease? Small disease there. Yeah. Again, if you have any question, just push on the microphone, and then
just waiting
ask
to
your
clean.
question.
So you see that the disease is below, and I'm shaving the backside of the uterus.
Yeah.
Trying to remove
Philippa,
all the
you use an aspirate, smoke evacuator, no?
No.
No, but no, it's a question because so far I didn't find a good one. So if you had a good idea.
Now we have the heating device from stores to the gas, but it's the only.
Yeah, but I think I've tried all existing devices in the market so far without any success.
We are reaching the vesicovaginal space.
Okay, let's move a little bit with Elder. Yeah. Yeah, Elder, we see you.
Yeah, we are trying to push down the disease. I will ask some scissors.
And Elder, as you have the stent and the green, because now that you dissect the vesicovaginal space, and as you see on the left, you are going you start almost to reach on the Yabuki space.
Yeah.
Yeah,
Dissected it.
no, that is beautiful. But
Yeah.
yeah,
I
it
will. Give me the section, please. I will just touch the vagina to understand how deep we are, but I feel that we are in the, yeah, we see the green there, we see the bladder, or maybe the ureter, but I think it's the bladder. We are very central.
Yeah, because
Devagarinho.
Okay.
Yeah.
Okay.
Mais lateral.
Okay. Okay, I will put my fingers in the vagina. This is something that by robotics is not simple to do. We have done some cases similar to this by robotics, but we cannot check the vagina so simple. Let me see. Okay, yeah, this is vagina. I have my section irrigated on the vagina.
Ouais, voilà.
So the bladder is below. I think we can open the bladder and try to make the excision of the nodule. There is some adenomyosis here. I will remove this maybe with the monopolar hook, and that's it.
I have a question, Elder, and maybe your colleagues, urologists, could help.
Yeah.
You know, when we do this, we like what you do. So I mean that dissecting the paravesical space, then dissecting the vesico-vaginal space, and then opening the bladder. My question is, when is the good time to open the bladder? Because when the bladder will be open, you will see exactly the limit, the internal limit or the mucosal limit of the nodule, and you will see your stent and the ureteric So when for you is a good time to open? What is your condition to start to open the bladder?
When you have the lesion, of course, all dissected, you know the limit. Sometimes there's an advantage not to open the anterior part of the section, not to do the anterior dissection of the bladder, because if you do that, the bladder it's stuck in the anterior part, so it opens more widely, and you can easily see the lesion. But here we did it just to show the dissection. But usually, I think now we know the limits. We've seen the beforehand the limits, and you know it's relatively 1 to 2 centimeters away from the ureters. So I think now we are ready to begin with the excision, the opening of the bladder.
So what you say, if I understand well, is to dissect the nodule, and then when the nodule is identified and free, you open.
Yeah.
Okay.
Yes, to have the margin, no, because I have to close it. But when you have all the nodule dissected, I think you are ready to open it.
Yeah, now we are starting to perform the shaving of the bladder nodule. Here we also follow the principles that we follow in the posterior compartment. We try to do the shaving as much as possible in order to perform the partial cystectomy, the smallest hole needed, because sometimes in the superficial serosa and even in the trusor, we have a bigger lesion than inside the mucosa, and in this way we are less aggressive, and we can preserve more bladder for these patients and reduce the risk of that smaller bladder syndrome.
Helder, nice job. Can I just make a comment? It is easier to get into the bladder if you fill it up a little bit. I know you do have ICG now that makes it kind of easier to recognize that. If you do not have ICG, the great trick is just to clamp the ureter or fill it up a little bit, and then it's much easier to get in.
Yeah, that's a good advice. We already opened the bladder. Aspirate section.
Helder,
Yes.
Philip here. I would like to have some discussion to understand.
Please.
For 20 years, we are saying the bladder open on top and not below. Do you think HCG changed?
Yeah, that is true. It's always easier to open the vagina from above, but in this situation, as we put the stents, as we are using ICG, we are more confident to open the bladder like this, because we are.
Helder, can you take a moment, put the scope inside the bladder and show us the stents?
Yeah, we will do it. Just aspirate, you see? So we are quite far. The disease is here, you see?
Okay, we look at you. Let's go a minute to Philippa, that the nodule is almost gone. Philippa.
I was waiting for you. So we have all the nodule isolated. I tried to shave it from the backside of the vagina in order to be more conservative. I pull it up. Here on the right side, I already have a small hole inside the vagina here.
Yeah.
And now I'm just going to remove the rest. If we go inside, we have to put a glove inside the vagina in order to not to lose the gas.
Mm-hmm. So that was a big nodule. And we see very nicely that you are in you're resected fully. It's beautiful.
Now I'm trying again, preserving as much as possible the vagina. If I see that there is no disease, well, okay. So the nodule is out, as you can see.
Yeah.
And we're going to remove it through the vagina.
Very nice. Okay, let's go. We follow you. Let's go to Elder.
Yes, we're just going to do the hemostasis and to remove the gauze through the vagina. And then we move to the vaginal closure.
Okay.
Ortica.
Elder.
So to close the bladder, there are different ways. This is a big hole, as you can see. Yesterday, it was presented by Anastasia. Different approaches. I like this way to put one stitch on one corner, another stitch on the other corner, and with this thread, we take the first layer, taking the mucosa, and with the other side, we take the trouser and the serosa, as was said, trying to close the mucosa and don't have exposed mucosa to avoid the situation that was presented yesterday. But again, we make the intracorporeal suture. We can use monofilament, or we can use even barbed suture. We like to use the Vicryl. Also, the urologist here, it's the one that they recommend. But anyway, it's possible. I learned with Professor Vatier to use the monocryle, the monofilament, but I think the most important is to close the bladder in the proper way, and after to test the closure of the bladder also in the good way. So I make this stitch here. I take another thread. I make a reference on the other angle. Now I want another stitch.
Toca primeiro. Deixa eu ver.
I will make another stitch there. I leave the needle there, and then I go from right to left in the second layer. Okay, we clean the scope. In this stage of the case, when there is some small bleeders, the quality of the picture can become a little bit worse.
Elder,
Yes.
how long do you leave the Foley catheter and the stents after surgery?
In this case, big nodule, at least 10 days. Let me see. At least 10 days, but 2 weeks would be probably better. And if we are in doubt, we do a cystography before we remove the Foley to be safe that the bladder repair is okay.
And the stents?
See, to be economical, I pull the long tip of the thread. I leave the small one there to have enough thread, as we learned with our master in suturing, Istvan Argai. I hope he's there. Greetings, Istvan, are you there?
He's taking coffee. Look, Elder, and the stents, do you remove after surgery?
Sorry?
The stents. The GA. The double G.
We leave them.
May I say something?
Yes.
Well, I would say that in this case, there is no ureteral lesion. There's nothing close to the ureter. We can take it out after surgeries.
Okay. Thank you.
The stents, so it's very easy. In the end of surgery, we just take it out. Regarding the time of the catheterization time, usually in the it's a two-layer well-closed system. You can leave it just 1 week. The thing is, when there is a big punch of the bladder that is taken out, the bladder will have a reduced capacity, and sometimes you can leave it longer. But usually 1 week it's enough for a bladder closure.
You see, I like to hold the thread that gives me a nice exposure of the mucosa. I keep the needle on the screen. I use the needle holder to pull the thread. Again, as I told you, I like to do this. It gives us exposition of the mucosa. And again, I should tell you that having the double J stents over there, we feel much better, much more confident when we perform these stitches, because we never know that we are performing a kinking or we are taking the ureter on the bite. So, of course, we spend some time. Of course.
Elder,
Yes?
can you comment on the use of barb suture with your colleague urologist? Because I would like to know what is his opinion on this.
We've used it.
Yeah.
But normally we don't use it in most surgeries. So of course, for laparoscopic purposes, perhaps it can ease a little bit the closure. So I have nothing against really, but just it's a question of habits.
In fact, and Miguel, I think we can say it, by robotics we use more barbed suture, and then by laparoscopy, I don't know why, but...
habits, yeah, and nothing against it. We usually barbed sutures for doing the prostatectomy, so and for What I just don't like to use barb sutures in the ureter. When we use the ureter, I think barb sutures may have some holes that can, it's a very delicate tissue, it's a problem. Urethra and for bladder, I don't think that's a problem. So we use barb sutures. So
Okay. And because I think the barb suture again is like for the bowel. So I mean, on the bladder, and I think maybe the bladder is less fragile compared to bowel for ischemia. But when you use barb suture, I think you have to handle the tension correctly to not be too ischemic.
Yes.
Okay, so we continue with you on the screen. Let's go to Philippa, that closed vagina now. Philippa,
Yes.
Vicryl also. The Vicryl is
Okay.
the king today.
So we removed the small lesions that were in the vesical uterine pouch. Already
Yeah, we have
removed
seen.
them.
Yeah.
And now we are closing the vagina. So I will do a vertical continuous suture with Vicryl, not with barb suture.
Philippa, we already spoke about the way of closing vagina, and we are saying here that if you close longitudinal, you can make it short instead of transversal. What do you think?
No, if you make it vertical, you can, it won't be shortened, it will be more tight. So if I have a really big nodule with a back defect of the vagina, I would prefer to close it vertically and not to decrease the length of the vagina. Because when you close it horizontally, you will decrease the length of the vagina.
Philip is there, and the time flies. This is a typical question in this endometriosis courses, if we should close it vertical or horizontal. And I never forget that they made this question to Philip, and he said very nicely, it's a matter of taste. You keep the same opinion, Philip? Is there or not?
I think it's a cul-de-sac. To come to the comment on the vaginal closure, I think as we say, the function creates the organs, and we know that the vagina is super elastic and will find its normal shape. So even if you are a little bit stenotic, I don't feel that it's a big important. What is important is the cul-de-sac. So I mean that if you remove the posterior cul-de-sac in terms of dyspareunia, you may generate dyspareunia. So that's why maybe sometimes the longitudinal closure at the end of the cul-de-sac may be better. But again, we don't have data, it's just an impression. Same question for you. Any experience? You don't use barb suture for what you do?
Question for me?
For you, yeah.
If I don't use barb suture?
If you don't use barb suture for doing what you do, what do you think?
To close the vagina, generally no. I use barb suture for myomectomies.
Okay.
I really like them for myomectomies. For the vagina, most of the patients, well, they stay with the threat about like 3 months. And I think with Vicryl, they will have faster healing. I don't know what is your impression.
No, but I ask you the question because, for example, for hysterectomies and vaginal cuff closure, we move now 100% with barb suture, and we are quite happy with the result. So now for this type of vaginal opening during endo, we don't have a lot of experience so far with barb, but that is discussion is open.
But even for hysterectomy, how long you advise not to have intercourse?
We keep at 6 weeks, so this is 6 weeks. I don't know why 6 weeks, but this is always what we say, and we didn't change with the use of the barb. We still say 6 weeks.
But you examine the patient before?
Yeah, we see the patient at 6 weeks post-op, and we give the clearance for sexual intercourse. And the feeling is that when you close with barb suture and you examine the patient, I don't feel my experience.
And you don't see the thread inside the vagina?
No.
With the barb suture?
We've done the same thing in the United States. By the way, Philippa, great job. I think this incision was small anyway, so it would have not affect any length of vagina, closing it transversely or vertically. But we have done also, for the last 3-4 years, we have switched completely to barb suture, and we have not had any problems. And we also follow the rule of 6 weeks, no sex after surgery, and we do not really see any difference.
So let's go back to Elder.
Yeah, now we are using the needle that I put in the right angle, and I'm coming back to the left side, double layer. In this double layer, as was said yesterday by Professor Vatier, it's very important to avoid to expose the mucosa, and we take the trouser, we take the serosa to cover the mucosa on that location.
We have a question for Philippa. We stay
Yes.
with you, but Philippa, you have a question?
We see how perfect Philippa suture the vagina, and we see Philippa don't lose the gas and uterus in hyperantiflexion. What kind of manipulator is Philippa using, uterine manipulator?
I'm sorry, but you have to repeat the question because closer to the mic.
The question was how you make to not lose the gas. So
what type manipulator is Philippa using?
I have a really simple manipulator that is the Cohen probe. And not to lose the gas, we put a glove inside the vagina with some gauzes inside to avoid the gas leakage.
you put a glove, you put gauze on the glove, and you put on the vagina.
Yes, and the simple manipulator, probe.
Yeah, a really simple manipulator that will allow us to perform the chromatubation to see the tube patency after. It's the normal one, the simple one.
So we use a Tintara Valchef simple manipulator. For this type of nodule, what is interesting is a manipulator that anti-flex importantly. So you have the Keckstein manipulator, which is made specifically for that. Yeah. But Tintara also does it, so it's fine. Okay, let's go back to you, Elder.
Yes, we made the double layer closure. We will do the test now with 100 cc's, 150.
And you do the test with what? With blue or with ICG?
In this situation, we will use with the. Do we have with the blue? With the blue, yeah. Okay. Normally with ICG, but the nurse prepared the. Okay, let's test this. And okay, prepare a stitch in case I need to reinforce some area. Yeah, you can inject. Luis Castro is injecting. He's a young colleague of our team. Okay, that's fine. There is a small leakage there, but
Alors, can we comment about the leakage? Is that important to be watertight or not?
Not completely. I think Miguel is here. He can say a few words on that, but here we will make a reinforcement stitch.
It's not important because we do a lot of times we do cystostomy miss, and we take it so you make a hole like 1 centimeter wide, and it closures if it's the bladder is catheterized, it closures. The thing is here, if it's a lot of mucosa exposed, that can be a problem. So if my suggestion is if there is a big leakage with mucosa exposed, we have to make another stitch.
Yeah. This is also my impression. I'm not sure that being totally watertight is important. I try to be, but I'm not sure that it's super. But as you say, I think the mucosa is more important.
Let's clean the scope. Yes.
The problem of those leakage on the corner is that the proximity of the ureter, no?
Yeah. Okay, we will reinforce a little bit, but we have here the corner that was referred. That gives us some. Remove your. Okay, I will take a bit more. Okay. People say that we need a robot to perform a precise suturing, but if we have the proper training, again, I want to highlight the program developed by the academy, led by Istvan Argai. That is very important to train and to learn how to do laparoscopic suturing in a precise way. It's very important to load the needle in the correct way, and of course to perform the stitch. Okay, let me see. Remove it. Now show me the.
Okay, there we follow you. Just a discussion with Philippa about the cystectomy now. What is your technique to protect the ovarian reserve?
I was waiting for your question.
Of course. But I see that you anticipate and you pay attention. I see that.
No. Well, of course, if we are speaking about ovarian preservation, this is not the best technique to perform. So to decrease the risk of affecting the ovarian reserve, the best thing I would say that it would be either alcoholization, either vaporization.
But Alberto told us don't touch the ovary.
Well, in this case, also it's really important to discuss with the patient. So she has even with an AMH of 1.3. All the treatments that she performed, she had a really poor ovarian response, and they decided to move forward ovarian donation. So we decided to be more aggressive to the ovary, removing the cysts, decreasing the risk of ovarian recurrence.
If the patient is going for egg donation, you can do what you want with the ovary.
Thank you. Thank you, Alberto. Only because of that. But even though we have to stay close to the cleavage plane in between the ovary and the capsula, I don't think you are you seeing it?
Yeah, but I have a question for yeah, that is not okay. My question was before that, but okay, right. Forget it. No question.
Oh my God.
No, but I was wanted to ask. Now you coagulate is not good, but before you coagulate, I wanted to ask to Alberto. Do you think that if you do a cystectomy precisely like she does, except the coagulation, I mean, you really damage the ovary or no?
The moment you do the cystectomy, you damage because you take in follicles with you. This is clear. But a good discussion is not to coagulate or to minimize this and close the ovary. It's another discussion. You can do it also. Some people does.
But we
Closing the ovary.
always do and put some hemostatic agent.
Yeah, it's an option because coagulation really damage also the reserve.
May I give a small comment for everybody? If you coagulate, in order to coagulate less than 2 millimeters of depth, you need a very pinpoint coagulator and activate for less, like you showed, less than 1 or 2 seconds. Otherwise, you go always deeper.
Otherwise, you are fired. In my team. Huh?
But it means that all the stars manipulate, it's not pointed enough.
So, Philippa, you have listened, huh? Pinpoint less than, how many, 2 seconds?
Demo un lift here. Lift here.
Alors, Elder.
Yes, now we finalized. I don't know if you have seen, we need to make an extra stitches on the anterior.
Yeah. We follow you all the time. We have followed you all the time.
Now there is this nodule on the left uterosacral ligament that we will approach. We like this technique that we learn with you, the ovariopexy using the T-lift, very clever device. It helps a lot, gives us exposition and frees the assistant to help us in the job. I will open a little bit here again because we see the ureter. Because of the ICG, I will not go for the ureterolysis. I will just I can use a scissors here, or I can use this ligature. I will open the peritoneum in this area, just medial to the ureter, and then using traction and contratraction, I will open this pararectal space, medial to the ureter. I will ask Miguel just to hold the peritoneum here. Okay, I find the scissors a little bit more elegant, but with this new tip of the ligature, I think we can be also precise in our dissection. And again, as I told you, if there is a small bleeder, we should go there immediately to keep our vision fine. I'm trying to delimitate laterally the nodule. The nodule is here. Again, I also like very much the monopolar hook. I will ask the monopolar hook. I can perform ureterolysis there, but I don't think there is the need because we see with the ICG where is the ureteric pathway. And in monopolar, we have this mode that is more coagulation mode. You see the tissue effect, more desiccation, a little bit of fulguration, but we have good hemostasis. But again, I really love the simplicity of this hook if we use the monopolar in the proper way. It is a non-touch technique when we want to vaporize the tissue, when we want to desiccate the tissue. And here I'm desiccating and this tissue becomes white, but also I'm vaporizing. If I push the yellow pedal, I cause more vaporization and less desiccation, but you see, immediately I cause the bleeding. Again, if I push the yellow, I vaporize more, but if I push the blue, like I'm doing now, I cause some hemostasis, and I have this, I think in these situations, in the uterosacrals, it's very helpful to have this, because in one instrument, you have more versatility if you know how to use the energy in the proper way. Again, I will ask Miguel to hold the uterosacral ligament. We are just anatomy. We are working very far from the bowel, but you see the bowel is this yellow. Yellow belongs to the bowel. It's the same as the yellow belongs to the bladder in the anterior compartment. So we have to be aware of that. I could open more the paravesical space here, but because I'm confident with the ureter laterally identified by the ICG, and because I feel that I'm far from the bowel, I'm doing this like you see. There is a bleeding here. I will ask the section irrigator to my nurse. Anyway, it stopped.
So let's go a minute with Philippa that assess the bowel to see. Philippa? So I have seen that you
we are
look at the
coming to
bowel.
the end, and we are going to perform the safety checks, namely of the bowel. So we know that we did the shave around here. That means that I will use a bowel clamp, and Sonia will put her clamp in front of mine in order to clamp the bowel. I will fill up the pouch of Douglas with saline, and João will put a gas through the anus in order to see if everything is okay. Peter?
No bubbles.
Have to repeat.
Can I
So
ask a question?
the gas will show if we have a small hole or not. Tira?
No
And you
bubbles.
see that no gas. Then we're going to fill up the syringe with the methylene blue. And sometimes when you do an aggressive shaving, if we remove the serosa and the muscularis of the bowel, you will see the mucosa by transparency with the blue below. So what we want to see if we have any fragility of the bowel walls with the blue. So João is going to put the blue inside, and you see that everything is okay with no bulging.
Okay. You have a question, Philippa?
Yeah.
I have a short question. Thank you for the beautiful surgery. I was wondering about the ovary because we discussed in the course to when you do a cystectomy to close the ovary afterwards. You didn't do that. Are you still going to do that, or what's your opinion on this?
No, only if you have a huge destruction of the ovary, I will do a closure of a closure with suture. But if you look to the ovary, it closes by itself. So I don't think it's useful to close this small incision.
Yeah, I think this is the point. You have two main reasons to close the ovary. Either, as Philippa said, because you remove a large cyst and your ovary become flat, so you reconstruct the ovary. And the second reason is to put some hemostatic agent inside. On that case, I think she's right.
May I have a comment about the endometrioma treatment? Because last week I was at the meeting of the French Society of Gynecologic Surgery, and the team from Clermont-Ferrand says that they will in a short time they will publish results against alcoholization regard to the ovarian reserve. So they stop to say that it's a very good technique for women who wants to be pregnant. And probably I will agree with Alberto, when you have women who want to be pregnant, you better not to do nothing, just open, wash, and make a preservation if needed.
Yes, but even a cyst of this size has no indication for surgery in a patient that is trying to get pregnant. It's a 3 centimeters endometrioma. So if she wants to get pregnant and if we want to preserve the ovarian reserve, you should not touch the cyst. This is only because this patient already decides to perform oocyte donation in the next cycle. And that means that the main goal of the surgery is not only restoring anatomy, reducing inflammation, but also getting free of the disease and the pain that she has.
Yes, you should.
May I make a question to the panel and to the audience?
Yeah.
We just tried a few times that diode laser that causes a very superficial hemostasis for ovarian endometriomas. Of course, the ones bigger than 4, and to avoid, of course, to impair the fertility. Anyone has experience with that for ovarian endometriomas, the diode laser?
Yeah. We have this because we do actually also in a study comparing cystectomy versus sclerotherapy versus laser.
Yeah.
And then to comment on the sclerotherapy, the recurrence rate in our series is 9% so far. Alors, there is a paper already by Roman that shows that even after sclerotherapy, we have a drop of the AMH. And so maybe it's true that even sclerotherapy damaged the ovary. Now, in the opposite way, you have to pay attention also to the ovary. I think we cannot just say don't touch the ovary because in our series, I think we have 6 ovarian cancer already the last 3-4 years. So we have also that in perspective. So I mean, it's super difficult. It's interesting to discuss, but it's super difficult. I still believe that a cystectomy well done can be acceptable, providing that the cyst is not too big.
I have a question.
Yeah.
So there is literature to suggest that people with bowel endometriosis getting assisted reproductive technology like IVF, excision of bowel endometriosis improves the success of ART. So in counseling your patients, and Alberto can also comment on this, should we be doing bowel resections for those planning for IVF and counseling them on improved success rates, or should we leave it to the patient to completely decide, to your point? What are your thoughts?
The bowel resection, you speak. We have these 2 big studies waiting for results. Nowadays, not clear data about bowel resection improves fertility with endometriosis. This is not clear.
Not for naturals, but ART, so IVF. IVF success.
Following IVF is not clear that improves doing bowel before doing IVF after. It's not clear. But as Philip says, to do randomized is not easy because a lot of factors.
You can never do a randomized study.
They are doing that. These 2 studies, we wait for that.
I think, when we were discussing shaving versus discoid or versus segmental, but mainly shaving versus the more radical technique, we were hoping that the spontaneous fertility will increase, not the IVF, the spontaneous fertility will increase. And we have only one paper that published the results showing that that's true. But unfortunately, it doesn't come out from many papers. Sorry? Elder.
We will remove the specimens, but we will test the tubes with ICG. This is something that I showed yesterday, an interesting application, very simple. Before we use the methylene blue, I will ask Luis to inject ICG. You have seen in the left uterosacral ligament, there was a nodule that we excised. Also, we identified the nerves. Maybe as soon as Luis completes the insertion of the tube in the uterine manipulator. You see, this is a school of laparoscopy. We have always different colleagues assisting and helping. And this is nice because they inject ICG. You see, you can see the ICG here on the left and on the right. Show me the right one. And also, this tube is not so clear. Let me see. Show, yeah. Inject, okay. And this tube is not so clear. But anyway, it's an alternative. And with this new camera, with this new scope, we can have this beautiful vision. Let's inject again with some more. Now on the left, it's clear. Let's check the right side. Sometimes it's therapeutic to make this tubes patency check, but unfortunately in this situation, I don't think it's okay. Well, we finalized. Normally, we make an inspection of hemostasis. We open also a little bit the rectovaginal space, but here was quite simple.
Any place for anti-adhesion barrier?
Yeah, normally we use that for dry field, but also the ringer lactate is an option in many cases, and I think that's it. So we will leave the Foley catheter for how many days, Miguel? 1 week. 1 week.
Okay.
And we will, of course, keep the stents. Probably we will remove them after the surgery.
I must say that I'm a little bit more prudent. I leave it for 2 weeks, and I always do a cystography before removing. But I'm sure it's too much.
We open bladder lots of times, and we just leave 1 week, and that's enough.
I didn't say it, Prof. But anyway, we will share with you the follow-up, of course.
Okay.
I don't know if there are more questions from the audience, but the quality of the image is still okay and the sound is still okay?
Yeah, everything is still okay. So we come to the end. Thank you, both of you. Thank you, Philippa.
Thank you to all. Just regarding the...
Can I make a comment before you guys end? Thank you very much for this wonderful 2 surgeries from Portugal. This is the best testament for your teacher, Arnaud Vatier, who has really taught you guys really well. You've done very complex surgeries that went beautifully. And there is no better award for the professor or the teacher with seeing their proteges doing such great jobs.
Yeah.
So you guys did really great.
Bravo.
Yeah. See you soon all. Abraço. Obrigado.
Bye.
Beijinho, Filipe.
Because of you.
Beijinho, Filipe, João Alves e Sónia Barata. Abraço do Porto.
Okay.
Deus Alberto. Parabéns.
Bye.
Parabéns para vocês e obrigado.
Thank you very much for everything, and I thank you to all my team.
Okay.
See you next time. Thank you.
Thank you.
Okay. Coffee?
Sim. Obrigada.